we've got two experts here in the field of spina bifida and hydrocephalus, both respected surgeons, researchers, nurse practitioners, folks that we've had over the course of years that have come and joined us to speak. This year, though, we wanted to broaden this opportunity to not only the people that are in this room to be able to hear these presentations, but also we're doing a live webcast. So people that are tuned in right now at home on the webcast, thank you, first of all, for joining us. And everything that we have today is going to be eventually on our website as well. So if you hear something today and you want to listen back to it or hear it again, or you didn't quite grasp something, you'll be available to go onto the website and click on the link and be able to hear everything that we talk about today. Also on the webcast, just for anybody that's listening at home right now or wherever they may be listening on the webcast, when you hear the portion later when we ask for questions, unfortunately we won't be able to take questions from anybody via the webcast or any online chat. The only questions that we'll be able to address are coming from those in this room right now. Earlier this summer, we invited members to ask the experts their questions. That's what I was addressing a little bit earlier about hydrocephalus. We received a range of questions on diagnosis, treatment, research, and the likes. And today we're fortunate and honored to have two noted neurosurgeons from the medical community with us today who are going to hopefully address and answer all of these questions. Dr. Abhaya Kulkarni, our first presenter, is a pediatric neurosurgeon and professor of surgery at the Hospital for Sick Children in Toronto, senior scientist at Sick Kids Research Institute, and program director for neurosurgery residency program at the University of Toronto. His bio is far more impressive than mine. He completed neurosurgery training at the University of Toronto and his PhD in clinical ophthalmology at McMaster University. After a pediatric neurosurgery fellowship at the Hospital Necker Infants in Paris, he began his faculty appointment at the Hospital for Sick Children in 2003. Dr. Kulkarni's research focuses on health outcome assessments in pediatric neurosurgery with special emphasis on hydrocephalus. He is a site investigator for the North American Hydrocephalus Clinical Research Network and has received research funding from several national and international funding agencies. He serves on the editorial boards of Neurosurgery and Journal of Neurosurgery, and he will be answering some of the pediatric hydrocephalus and spina bifida related questions that we received today for this event. So we'd like to welcome Dr. Kulkarni. Dr. Kulkarni is going to start the presentation in a moment. Before he does, though, I'll introduce our other expert, and we're pleased to welcome Dr. Andrew Parrent. He's our second presenter. Dr. Parrent received his BSc from Brock University in St. Catharines and his MD from the University of Toronto in 1983. He completed a neurosurgery residency at Dalhousie University in Halifax and a 2-year fellowship at neurosurgery at the Toronto Hospital. Dr. Parrent is assistant professor of neurosurgery at Western University and associate scientist at Robarts Research Institute in London. He's conducting research in collaboration with Terry Peters of the Robarts Institute to establish a computer-based image-guided surgical planning system for neurosurgical procedures, and he has developed an interactive video CD for teaching surgical techniques to his residents. Dr. Parrent has contributed to many medical textbooks and has been published in numerous journals, including the New England Journal of Medicine and Canadian Journal of Neurological Sciences. Dr. Parrent will be providing an adult care perspective to the questions that we receive. So please welcome Dr. Parrent as well. So Dr. Kulkarni is going to begin in a couple of moments' time here, and I know Dr. Parrent will have his perspective on some of the issues that Dr. Kulkarni and some of the questions that Dr. Kulkarni has, and then we will get more into Dr. Parrent's presentation as well over the course of the 10 or so questions and answers that we have here in the presentation. So we will get to that here in just a moment, and then we'll have our break for lunch. Prior to lunch, though, we will open it to the floor for some of your questions. So if you have any questions over the course of these presentations, jot them down. We will try and get to you. I'm going to have the microphone. I'll be able to come around and make sure that you're mic'd up so that the people listening on the webcast as well can clearly hear what the question is. And the one thing I would note as well is we'll try and keep the questions, if we can, to the issues specifically related to the presentations. We can't really get into individual cases. Understandably, you know, the doctors can't be here to diagnose you or to give an assessment without actually having met with you. So we're going to keep individual cases, let's say, out of this and more talk in generalities about spina bifida and hydrocephalus. So I'll turn it over now to Dr. Kulkarni.
Thank you so much. All right. So I was given the questions ahead of time, and they're actually all really very good and interesting questions. So they're all listed here. And I'll go over them in turn. So the first one was a very basic question. What are the most common shunt options available? And how do you determine which shunt is preferable over the other? So why would you use a ventriculoperitoneal shunt, a VP shunt, versus a VA, which is a ventriculoatrial shunt, or a ventriculopleural shunt, or a lumboperitoneal shunt? So there's a few ways to look at this. So first, you know, just so you understand, the ventriculoperitoneal shunt is the most common one that we do, and so that means a shunt that goes from the head underneath the skin, so subcutaneously to the abdomen. Okay, and that's the commonest thing. And why do we choose it over the different ones? So with the pleural shunt, that means it goes from the head into the chest cavity, okay, just around the lungs. And a ventriculoatrial shunt is one that we place from the head. It goes usually through one of the vessels in the neck to end up just in the heart. Okay, that's the atrium of the heart. So that's a ventriculoatrial shunt. And then a lumboperitoneal shunt is completely different. That, instead of draining CSF from the head, it drains CSF from the lower spine and then drains into the belly. So lumbar peritoneal. Okay. So I think part of the reason why why VP shunt is the most common is because some of the unique complications that we see with these other shunts. So they all have some idiosyncrasies with them. So pleural shunts are draining into the chest cavity, and one of the complications they can have is if you get a buildup of the CSF in the chest, you can imagine that it might be hard to breathe, right? It compresses the lungs. For most people, this is not a problem, but where it's especially a problem is if you're very young and you've got a very small chest to begin with, so young babies tend not to do well with the ventriculopleural shunt for that reason, or if you have some other sort of compromise to the chest. One situation we often run into is somebody with a severe scoliosis and sort of restricted chest compliance and volume. So those are situations where we might want to avoid putting extra fluid and compressing the lungs. With the ventriculoatrial shunt, the shunt draining into the heart cavity, one of the complications you can get from that is that the catheter can start developing blood clots on it. And it can block, or those clots can fracture off and then go to the lungs, and that can cause over long-term pulmonary hypertension or other problems with the lungs. And they're a little bit trickier to insert. I mean, we do it fairly routinely, but it is a slightly harder shunt to insert and to revise. So if you run into complications with them, it can be a bit more complicated. Lumboperitoneal shunt, one of the unique complications with these is that you're draining off fluid from the lower part of the spine, and what that kind of does is it sort of sucks the fluid in the brain down, and so you can develop a secondary Chiari malformation, which means that the lower part of the cerebellum of the brain gets sucked down into the upper part of the spinal area where it shouldn't be. Usually that's tolerated, but sometimes that can cause problems. So that's one of the reasons we try to avoid that, and also it is a little bit trickier to insert. And did you have any comments about that?
Oh, thanks, Ab. It's hard to add to that presentation. Just one sec here. My perspective is primarily the adult perspective. There we go. And for all the reasons that you've mentioned, I would say the peritoneal shunting is the commonest procedure we do. That's really the go-to procedure for most adults with hydrocephalus. The main reason we would change that is if we run into people who have peritoneal issues. So if somebody's had operations on their abdomen, gallbladder taken out, an appendix taken out, operations for various abnormalities in the gut, you can run into problems where the gut just simply doesn't have the capacity to absorb the fluid that you're trying to put into it. And we would look for alternate options, and usually the second place we would go to would be the lung. And in adults, although the same issues can arise, of course, adults' head to lung ratio, the lungs are much bigger, and they usually will accommodate the fluid absorption in the lung. The other condition that we tend to see in adulthood, which isn't really hydrocephalus, but it is along the spectrum that we think of as CSF disorders, is a condition referred to as idiopathic intracranial hypertension, where individuals will have very, very high pressures inside their head, in spite of the fact that their ventricles are very, very small. And we still need to divert their spinal fluid in order to treat that condition. And although one can put shunts inside the brain under those conditions, putting shunts into very small ventricles carries with it a slightly higher risk than putting shunts into very big ventricles, for obvious reasons. And we would tend to put shunts in the lumbar cavity and shunt that fluid into the abdominal space. I'm not really sure, Ab, about the Chiari complication, whether that is more a result of the growing child. We don't tend to see it very often in adulthood. So as your spine is growing and you're siphoning fluid off the lumbar spine, as Ab was saying, the risk is that the lower parts of the brain tend to come into the upper part of the spinal canal. In a full-grown adult, we tend not to see that. So the lumboperitoneal shunt is a little more acceptable in an adult condition. The other thing that I think we'll talk a little bit more about when we talk about ETVs is this concept of hydrocephalus that is communicating hydrocephalus and hydrocephalus that is non-communicating hydrocephalus. We make spinal fluid in the ventricles of the brain, and that fluid has to get out of the ventricles, and then it travels around the spinal canal, comes up, travels around the brain, and gets absorbed. If the fluid doesn't get out of the ventricular system, and there are a number of reasons why that might be the case, then treating hydrocephalus by shunting fluid out of the lumbar spine doesn't make any sense at all, because you're not really treating the fluid where it's blocked. And a ventricular peritoneal shunt would really be the only option for that. So lumboperitoneal shunt would be restricted to conditions that we refer to as communicating hydrocephalus.
Great, thank you. All right, so then we'll get into this. The next question was about ETV, so endoscopic third ventriculostomy. Is this considered as the first preferable treatment option for anyone with hydrocephalus? How do you determine who is a good candidate, and why choose an ETV over a shunt? So great question. So just so everyone's aware what an ETV actually is, if we have here a slide of somebody with hydrocephalus, here you see a situation where the fluid is blocked here. So as Dr. Parrent was saying, this is a non-communicating obstructive type of hydrocephalus. And so the fluid is all built up here. And we could put a shunt into these ventricles and drain the fluid that way. Or we could put an endoscopic camera through the brain into the ventricles and then make a hole here at the lower part of the third ventricle, and that forms an internal bypass so that all the fluid that's blocked up here that normally should be flowing out this way but can't, can now flow out this way. Okay? So that's what an ETV is. And when I think about assessing a patient with hydrocephalus and deciding about ETV, I think the two questions that I pose are, one, is the anatomy suitable? And that means, can I actually do the ETV safely? Because there may be things on the anatomy of that patient that make an ETV just out of the question anyway. And then the second question, if that threshold is crossed, is should we do an ETV on that patient? Is it the right decision for that patient if you look at the totality of their picture? So in terms of the suitable anatomy, the things that we look for are, we need to place an endoscope into the ventricles. So the ventricles have to be at least a minimum size. So it's very difficult to do this in somebody who has small ventricles. So that's one thing. And then similarly, the next stage of this operation, after you get the endoscope into the ventricles, is to actually make that hole in the floor of the third ventricle. And so the things that I would look for there is that floor thin enough that it would be safe to make a hole through it? Is the angle of the floor good? There's a number of other nuances that we would look at to determine whether it's safe to make that hole. And then I think about, what am I going to see after we make that hole? On the other side of that, is there a safe landing pad, basically, on the other side? How much space is there? Where is the major arteries in that area? Is there a lot of scarring? All these things we look at. So as an example, this is a child with hydrocephalus, and here, this is the floor of the third ventricle. And it's a little bit unusual. It's nice that it's bowed down, which is what we like to see, but I don't like this angle here. It's going to be quite a difficult one, and I suspect there's some scarring underneath here. You probably don't appreciate this, just me telling it to you, so I have to take my word for it. There is. And similarly in this one, this is another case where the floor of the third ventricle looks very nice. It's nice and thin, which is what I'd like to see. The angle's good, but what I worry about here is there's not a lot of space in this area. I'd like to see more white here. And as well, there is evidence that there may be some scarring in this. This one we actually attempted an ETV on, but because I wasn't sure if the scarring was there or not, but scarring was in fact there when we went. So that's the question of whether you can do the ETV. Should you do the ETV? Comes down to, I think, some issues about the patient's circumstances, and that relates primarily to the age of the patient and what the cause of their hydrocephalus is. The best case scenarios for ETV, meaning the situations where ETV has the highest success rate, are older children or adults who have a pure obstructive, non-communicating hydrocephalus. So some sort of a discrete blockage from whether it might be a tumor or a congenital blockage of that fluid. Okay? Anything that's different from that, meaning a different type of hydrocephalus or a different age, particularly infants, then they are less than ideal candidates for ETV because we know that the success rate is lower. And this is one way to quantify the success rate. This is for children, this ETV success score, and you get scores that get higher as you get older, and they get higher as you change etiologies or causes of hydrocephalus. So the worst case scenario is post-infectious hydrocephalus, and then things like myelomeningocele and intraventricular hemorrhage are next worse, and then the best are the aqueductal stenosis and what we call tectal tumors. Okay? And then that quantifies what the chance of success is with ETV. And if we compare the results for shunt versus ETV on patients who would have been good ETV candidates, so they have a high success score, we can see that, in fact, they actually do quite well. So what these are curves that tell you how quickly you fail your procedure, all right? So if you failed, sorry, my cursor doesn't show up on this one. Okay. There's not a pointer here. Anybody have a pointer? No. So these curves, as you see them go down, a very poor procedure, one that fails a lot, would have a curve that goes really steeply down, okay? One that's perfect would be a straight line right across the top. So you can see that ETV and shunt are neither perfect nor terrible in this group of patients. But you can see that ETV is a little bit higher, okay? So lower failure rate, higher success rate. So this is the type of patients that we're talking about, who are the older patients who have that discrete obstructive hydrocephalus. This is the best case scenario for ETV. If you look at patients who are less good candidates for this, so they may be slightly younger, they may have a different cause of hydrocephalus, this is what those curves look like. So here, the curves are a bit closer together. ETV does a little bit worse early on, as you can see, but then they kind of overlap. So not much of a difference in this sort of middle group. And then when you get to the patients who are the worst candidates for ETV, and these are, unfortunately, the majority of patients that we see, because these are almost all infants, right? Because that's the strongest predictor of failure with ETV is being very young. So this is what the curves look like there, and you can see the ETV curve drops off dramatically very early on. So very high failure rate early on. And the shunt also, drops off a fair bit, but there is that gap where shunt seems to do better in this group of patients. So when you look at those curves, why do we consider ETV at all? I should mention it is a riskier procedure to do. So as an actual operation, the risks of the actual operation are a little bit higher than with shunt. So we know that. We also know that it has a higher failure rate in many patients. So why do we attempt it? Some of the reasons are, one, it does have a lower infection rate because we're not leaving any foreign material in the patient, so the infection rate is lower, and as well the late failure rate is lower. So this is a kind of hard curve to grasp, but what it's basically trying to show you graphically is that over time, so if you go from left to right, that's years from surgery, years after your surgery, whether it be shunt or ETV. On the vertical axis going up and down is what your risk of ETV failure is compared to shunt failure at any point in time. So what it's trying to show you is that early on, in that left part of the graph, the curve is the line is fairly high, which means that your risk of failing with an ETV is higher than with shunt. So early on, shunt is actually better. Okay, your rate of failure in the first few months to maybe 3 to 6 months is actually higher with an ETV than with a shunt for most patients. But the reason we consider ETV is that after you cross that 6-month threshold, look what happens to that line. It goes way down, which means that at 2 years, 3 years, 4 years, or whenever, you can still have a failure with the ETV. It still may not work and you may need repeat surgery, but the chances of it are lower than with a shunt. So that's sort of the trade-off. You take, with an ETV, you're taking more early risk because there's a higher chance it's going to fail. But if it doesn't, if you're one of the patients in whom it doesn't fail early on, then you probably have a lower risk of ETV failure when you're 5 years out than having a shunt failure when you're 5 years out. So that's how we look at it. And any comments from the adult perspective on that?
Yeah, we don't deal with is a relatively unique group of individuals. First of all, to go back to some of the anatomical stuff that Ab was starting to talk about, when we talked about hydrocephalus being a buildup of fluid inside the head, and what does an ETV actually do? If we look at the diagram on the far left, silhouetted inside the head are the ventricles. The C-shaped cavities are what we call the lateral ventricles, and they feed into that middle cavity, which is the third ventricle. And in the middle picture here, you can see fluid is supposed to get out of that third ventricle by going through a little canal into the fourth ventricle, which is that little triangular-shaped structure, and then it's supposed to come out the bottom end of that. A very common condition we see is aqueductal stenosis or aqueductal narrowing. So in the far right picture, that canal narrows. Of course, in the setting where that narrows, then the fluid builds up behind that. And this area right here is the floor of the third ventricle. And all we're really doing is making a bypass. So you poke a little hole, fluid gets out, and it just resumes its journey over the top of the hemispheres. And that's why it makes intrinsic sense to do this in an individual who has blocked shunts, has obstructive hydrocephalus. So you make a hole right through that opening there, and that should get you in. So it creates a new pathway for the CSF to flow. Therefore, the ideal individual would be somebody who has a blockage of CSF flow. And one would have thought aqueductal stenosis is commonly thought of as a congenital condition, and indeed it is. But in the adult world, as I was starting to say, we see several distinct groups of individuals. Of course, we see the transition individuals, so people who have had hydrocephalus since they were born, were treated with a shunt, sometimes many shunts, and then they now graduate into adulthood, and they're no longer looked after by pediatric neurosurgeons, so we inherit a group of individuals who have hydrocephalus that's been treated. And where we get involved is that their shunt starts to malfunction. I personally dislike shunts. And I think anybody who has a shunt dislikes shunts. A shunt is a mechanical device. And you feel like your life and your health is dependent on this mechanical device. And indeed it is. And they're designed well, but they're not perfect. And as we age, we have to assume they just don't have the ability to last for 70 or 80 years. So we're inevitably in this cycle of replacing shunts. And it's hard to predict. We have individuals who can go for the better part of their life with a shunt that functions fine, and others who will have repeated malfunctions. So my goal in life is to destroy shunts one at a time. So every individual that comes through the door with hydrocephalus is somebody I would look at as a potential candidate for endoscopic third ventriculostomy or ETV, and then try to convince myself that I should not do it rather than to convince myself I should do it. The obvious low-hanging fruit are individuals who have aqueductal stenosis. In adults, we'll see tumors at the back of the brain that will also cause a similar condition. But it's become evident that there's a number of individuals who have what we traditionally think of as communicating hydrocephalus. Infants who have had intraventricular hemorrhage, so what we refer to as post-hemorrhagic hydrocephalus. Infants who have had infections like meningitis, so they have post-meningitic hydrocephalus. And the anatomy would suggest that this is communicating hydrocephalus. And there's been some interesting work that's come out of all places like sub-Saharan Africa, where the idea of putting a shunt in is cost prohibitive. They simply cannot afford to put shunts in. So they've been doing ETVs over and over and over again, and what we've learned in these groups of individuals that anywhere between half and 2/3 of these individuals may in fact be adequately treated with an ETV. So it's certainly something we explore in adults who come with these conditions. So the easy one is the aqueductal stenosis, and in adults with aqueductal stenosis, the success rate is exceedingly high. We're up in the 80 or 90% long-term success rate. For other conditions like communicating hydrocephalus, it's a lower success rate, and shunting may be better, but it's often a discussion I'll have with individuals to say we could look at doing an ETV, accepting that there may be a 30 or 40% or 50% failure. But the upside is if you're 25 or 30 years old and you're one of the 50%, in fact, that we can eliminate this shunt, it's a huge win for the rest of your adult life. The other condition that is unique to adulthood is this condition of normal pressure hydrocephalus, which is a condition that's becoming more common as the population ages. The baby boom bubble is getting older and older, and this is a condition we see in people who are in their 60s, 70s, and 80s, where the ventricles enlarge. There is no obvious reason why that should be the case, and they develop a syndrome that's characterized by a loss of cognitive powers, difficulty controlling urinary output, their urinary control, and walking difficulties. So they often start off with walking difficulties, balance difficulties, gait difficulties. Will go on to develop problems with urinary control, problems with cognition, and that triad alerts us to the fact that it might be NPH. The imaging will show they have big ventricles, and this truly is communicating hydrocephalus. And right now, it is a little controversial what the role of ETV might be. There are some places that do it, and there's certainly evidence that there's some success in doing it. The problem I have when I've done it is that if somebody improves a little, you're never certain whether they would have improved more if you do a shunt, so you're always weighing out the relative merits of doing one versus the other. So the jury's out on that condition right now.
Okay, thanks. All right, and carrying on with the ETV theme, the next question was what improvements have occurred surrounding ETV since they began being used as an alternative to shunt? So the main thing I think, and Andy alluded to this already, was from the experience in Uganda looking at an adjunct to ETV, which is choroid plexus cauterization. And so the choroid plexus is structures in the brain that create the CSF. And before shunts came along, which was about the mid part of the last century, this was one of the treatments for hydrocephalus. With little else to offer, the choroid plexus was a target of surgery, either surgeons trying to remove the choroid plexus or burn it. And it was very high failure rate because of the techniques in that were available 100 years ago. And then it was largely abandoned, and then through this experience in sub-Saharan Africa, promising results have come from the combination of using the endoscope to do the ETV and combine that with this choroid plexus cauterization. So I'll just show you what that looks like through an endoscope. So this is how we do this choroid plexus cauterization. Let's see if it works. Yeah, so this pink stuff, this pink frondy stuff here is the choroid plexus, and we're burning it here with this probe and just making it white, basically, trying to blanch all that and burn it. Okay, and we do that throughout both upper ventricles. And this is what it looks like at the end. So you remember it was sort of pink and robust, and now it's this sort of thin white line there. And then we're going through the other side, and again, you'll see on the other side we do the same thing. So you do this on both sides of the ventricle. There's sort of the thin white stuff there. So the results in Uganda have been pretty good, but the patient populations, the kids we see here are very different. And so we're looking at this now. Ben Wharf was the one who started this in Uganda. Now he's in Boston. He's published his initial experience of 91 infants with this procedure with close to a 60% success rate. And this is what the time to first treatment failure looks like, and it's actually not bad what he's showing. This is the experience from we have a hydrocephalus clinical research network that's Toronto belongs to across North America. And these are the results of this procedure from our first 36 infants that we treated. And so the results were okay, not great, not as good as shunt, and not much better than we would have predicted with ETV alone. But part of the problem was that we were, one of the important part of the procedure is to do a complete cauterization of the choroid plexus, to get all of it cauterized. And so when we were able to do that, the success rate was actually quite high. So we're exploring this right now. We're doing a prospective study, and we've done in the network close to 300 of these procedures, and we're in the process of looking at those results right now. So I don't know where it's going to fit in. The main benefit of this might be, and I don't know if this is actually going to pan out, but that it might allow ETV or endoscopic treatment to be applied to more infants. I think that's really what we're looking at here. Whether more infants might have a reasonable enough success rate with this procedure to make ETV worth doing over shunt as a first-line treatment, but we're still exploring that. We don't know where that's going to end up. Do you have any comments on that, Andy?
This is not something that's penetrated into the adult market yet.
Okay. All right, so the next two questions are related. So some newborns that have been diagnosed with hydrocephalus are not being shunted immediately. Under what circumstances might there be a delay in shunting? And would there be situations where enlarged ventricles may be monitored, then referred to a neurosurgeon? So this generally gets to the question of about thresholds for treatment. And there isn't a clear answer to this, right? This is some of it is objective, but a lot of it is subjective. And I think there's common agreement that when somebody's obviously very sick and demonstrating severe signs and symptoms of raised intracranial pressure with vomiting and irritability and lethargy, papilledema, critical changes in vital signs, I think nobody's going to argue that that person, that child, that infant, that adult needs treatment immediately. But beyond that, there's a lot of things that we consider. Things like in infants, the rate of increase in the head circumference, not just the absolute size of the ventricles, but what is the rate of change of the ventricles. In babies, we feel the fontanelle, how full is it? And you can get difference of opinions in that too, and that changes in a child, minute by minute as well. Whether there's sort of splaying of the sutures, so the skull bones moving apart, and headaches. All these things are things we look for, but I can't give you an exact recipe to tell you a priori if you meet this, and this, you're going to get treatment. If you're not, if you don't, then you're not. There's some idiosyncrasy to how we make these decisions, but those are sort of the general guidelines that I would use. And Andy, any comments on your end from that? Yeah.
Well, obviously we don't see kids with expanding heads in adulthood, but we do see the phenomenon of incidentally diagnosed hydrocephalus. There are adults who may in fact have large heads, which implies, and they have big ventricles, which would imply that they had hydrocephalus when they were infants and simply carried on into adulthood, either because they had no symptoms or they had minimal symptoms. And I'm not infrequently referred individuals who have come to the emergency department having had a minor head injury or some incidental condition or a bad migraine, they get a scan that shows enormous ventricles, and they're sent my way. And we have had this concept that's persisted in neurosurgical literature of arrested hydrocephalus or compensated hydrocephalus. The idea being that if your ventricles get to a certain size and yet you're not developing symptoms, that your brain must have got used to this, and therefore you don't need to worry about it ever again. There has been a bit of change in this concept over time, because we do, at the far end of the spectrum, when I talked about normal pressure hydrocephalus, we will also see older individuals present with this triad of hydrocephalus, with the gait problems, the urinary problems, and the cognitive problems, in the setting of a big head and clearly hydrocephalus that has been there for their entire life. So it's unclear whether individuals like this are at risk of developing further problems as they get older, and that's something we simply don't know about. So what we've tended to institute now is when somebody's sent to me with this, we do some baseline testing And we're entering them all into a registry where we are retesting them every 5 years or so to see whether there are subtle cognitive changes as time goes on, which may make us a little more proactive in treating the hydrocephalus prior to becoming symptomatic. But there's no question, individuals with large ventricles can live out in their entire life and be completely normal.
All right, next question is about antibiotic impregnated shunts, so very topical. So just to tell you about this, so these are shunt catheters that have been at the manufacturers impregnated with antibiotics. And when you implant these, the catheters themselves, so the part that goes into the brain and possibly the part that goes down into the belly, have this impregnation on them, but the valve itself does not. Okay, so the valve that we put in between those two catheters is not impregnated with the antibiotics. There's no randomized data yet on this, so we don't have sort of the best study yet to show whether this actually helps reduce the rate of infections or not. But there's a number of studies that are what we call observational studies. They're not the randomized trials. And I think if you look at the totality of these, there's some conflicting results, but I think they do suggest, on average, a slight degree of improvement in infection rate with the antibiotic-impregnated catheters versus not. What we found when we looked at this in our hydrocephalus research network, when we started, we put in shunts specifically without the antibiotic-impregnated catheters. And what we did instead was we gave antibiotics at the time of surgery, and then we actually injected antibiotics into the shunt itself when we finished the operation. So we found that had a certain infection rate. And then we changed our protocol so that we stopped injecting the antibiotics and instead put in these antibiotic-impregnated catheters, which are more expensive, by the way. And when we did that, we found that the infection rate was basically the same. So either of the two protocols that we used, one that didn't involve the antibiotic-impregnated catheters but did involve injection of antibiotics, led to a similar infection rate as with using the antibiotic-impregnated shunts. I think the best study on this is one that's ongoing right now. It's in the United Kingdom. They're doing a really nice national study that's a 3-arm randomized trial that will compare just regular shunt catheters to these antibiotic-impregnated catheters to silver-impregnated catheters as well. That's another type of catheter to try to reduce infection. So it's a 3-arm randomized trial. It's a very large study. They're in the sort of relatively early stages of it right now, so it's going to be a while before we get those results, but I think that will give us the best answer to this question. I'm expecting those are still going to be a few years away. Anything to add from your side?
We really need somebody in the adult world who's doing the degree of research that you and your group are doing through the Hydrocephalus Research Network, because they're collecting excellent data in children. We know the natural history of shunts in kids. We know the natural history of ETV in kids. We now are starting to understand the role of these catheters in kids, and we don't have equivalent data in adults right now. So right now, as I said, the best studies have been done in kids. Our sense right now is that they're not conclusively better than regular shunts. It's uncertain, particularly in this age of cost consciousness, whether it's worth the extra cost of putting an antibiotic impregnating catheter into an adult. We certainly consider it in somebody who presents with frequent shunt infections. But we're hoping that the data will emerge over time that will allow us to make sensible decisions. Because the reality is, it doesn't matter how expensive it is, if it stops repeated infections, the long range would be that it would be cheaper to be doing that than to be doing, and certainly safer than to be doing multiple operations.
So this question was about children with spina bifida living longer. Are more neurologists, neurosurgeons, and other doctors being trained and willing to care for children when they transition to adult care? Or are they considered too complicated? What are some of the roadblocks? So this is a great question, a very difficult one. I think it's complicated and it varies very much regionally. This is one that I don't have much information on directly, and I got this actually from Dr. Church, who's here in the audience, so she might be able to add more to this here. From our perspective here, we do try to transition them to adult neurosurgeons who have expressed enough interest and expertise in this area to be able to manage children who are now adults with these conditions. And as Dr. Church has told me that there is, maybe I can just ask you to comment directly rather than me paraphrasing your words. Is that okay, Paige? You want to?
Yeah. That's fine. So we were lucky. We have Bill Schatz here, our MP. Through the Toronto Central LHIN, we were asked to look at ways to make healthcare more efficient. And one of the major obstacles we have in pediatrics is moving children with any complex medical condition into adult medicine. We were then asked to pick a pilot population, and a little bit of the fox in the hen house. I automatically went for Spina Bifida. And so we created this transitional program where a nurse practitioner with a background in primary care meets our children in adolescence as they become adults and gets a relationship established with them, so that then as they approach 18, it isn't this crisis point of meeting a new healthcare provider for the first time. She's gotten to know them, she's gotten to know the ebbs and flows of their health, their baseline, and then as they approach 18 and they're no longer allowed to be in the pediatric world, and it's not necessarily in their best interest to, they transition over to the adult world with a bit of a navigator or a diplomat to help them succeed on the adult side. We're still in the process of working out our network for the subspecialties. We have interests sort of scattered around the hospitals, and sometimes that's not the best arrangement for people, so we're really trying to hone that down. But having that person that can be the sounding person for young adults as they go away, they may not see her that often, but if something comes up and they're not getting the answer they need, they can come back to her and say, does this make sense? That's huge. It's huge for young adults. So we're very excited. And Bill Shunt just joined us 2 weeks ago, 3 weeks ago. No, a month ago. Anyway. I was on vacation, so for me it was a little less time. Anyway, we're very excited to have her, and she's already doing a great job stepping in. So.
Well, I applaud those efforts because it's greatly needed. I mean, this is a difficult scenario, and it's certainly very poorly done at all centres across Ontario, as far as I can see, and we're no different. Partly the framework of adult patient care is very different than the framework of pediatric patient care. Pediatric hospitals have traditionally worked as in terms of comprehensive clinics. You go to a spina bifida clinic and you've got a neurosurgeon, a neurologist, urologist, an orthopedist who deal with all these issues. And we don't have that traditional setup in adult hospitals. One can very well ask why, and I don't have a good answer. The other thing that pediatric hospitals do very well is they have the child life workers who are there to support the parents and the patient as they go through this process. And in reality, what happens is individuals reach 18 years old and that just simply stops. And now they're adults and they're kind of left to navigate through the adult system. So I think having the idea of a transitional navigator would be very, very good. The issues, these are complex patients, and there's no question the treatment issues are complex, and there's also no question that you'll find surgeons who are not particularly interested in taking on something of great complexity. But in every center, there are individuals and surgeons who have the necessary expertise and the necessary interest as well. I think for people who are navigating their way through the system, it's very important to talk to your current neurologist or neurosurgeon, see if they can help in referring you to an adult who they know in another city who has the relevant expertise. I certainly get a number of handover, not just a letter saying, can you see this individual, but reams of notes and all the relevant background information on patients who are, in essence, graduated from a hospital for sick kids and who are resident in London, and we take over their care. But it is a process that is challenging, and I believe the ministry is starting to look at this a little more seriously and put some money into it.
Thanks. Okay, so the last pediatric-related question. What are your thoughts on intrauterine myelomeningocele repair? Quite a few surgeries have been performed in the U.S. Will we ever begin performing them here, and what challenges does babies still have after intrauterine repair? So this all comes from the randomized trial that was done in the U.S. Through the NIH that was halted in 2010 that suggested fetal surgery for myelomeningocele resulted in lower rates of shunting, lower rates of Chiari malformation, better walking ability, but higher rates of preterm birth and maternal complications. And once the results of that came out, the procedure is being done by many centers across the U.S. now. I will tell you there's some new data that just came out from Vanderbilt that has re-looked at some of the results of their fetal surgery and suggested that the benefits for shunting especially were restricted to those who started off with small ventricles. So that if they did the fetal surgery in a baby that already had big ventricles, the chances of avoiding a shunt in that scenario were quite low. So that might change some of the eligibility, but that's one of the challenges with this is there were strict eligibility criteria for that study, and so what the process right now that's happened is that families are screened, and those who are considered eligible through our centers here are then offered a referral to one of the American centers, and at least Toronto has generally been sending ours to Vanderbilt, and then they get assessed there and potentially offered surgery if they're deemed eligible. From perspective whether we'll actually do this here, so there is a growing interest in starting a fetal surgery program in Toronto. This would be not just for myelomeningocele surgery, but for a range of other fetal surgeries that are done. And so there's, I think now we're just about a point where there is sort of critical mass of interest amongst the maternal fetal doctors and the general surgeons, neurosurgeons, others who would be the relevant practitioners of this. So that is building right now. I don't know if we will for sure go ahead with this. I think it's likely that we will. Part of the problem is that it is it's still a small area, you know, and if even if all the cases from Canada were to come to one center, it's not a very large volume of cases. So it has to be justified because it takes a lot of time, effort, and resources to put a program like this together. So it may not be worth for us to do this in Canada if there are busy centers in the States who could easily handle the few cases that Canada sends their way. And I expect you don't have any comments on that. Okay. All right. Okay.
Thank you to Dr. Kulkarni. I'll kind of address some of the questions now from an adult perspective, specifically as Dr. Parrent kind of takes over the bulk here. And again, if Dr. Kulkarni has anything to add, but this is predominantly now dealing with the adult issues and some of the questions that we had. So, Dr. Parrent, the question was, I've had hydrocephalus since birth. I'm now 25. What can I expect with my condition as I age? For example, do revisions occur as frequently in adults as they do in children?
The simple answer to that is no. The challenge of putting a shunt in an infant is, of course, or a newborn, is that you have an individual that's expanding and growing over time, and that has some very practical issues with the mechanical device as a shunt. There are mandatory revisions. This really refers to that specific subgroup I talked about as transition patients, and once they make the transition into adulthood, there appears to be, for many of them, a period of relative stability. Although it is hit and miss, you can have individuals who have a problem with shunt obstruction or shunt infection, and sometimes you can get that, like 1 or 2 or 3 of these procedures back to back, and then a decade or 2 or 3 will go by with no further problems. But the reality is these are devices that don't last forever, so inevitably there comes a time when shunts need to be replaced. But there is no evidence that these are more frequent as an individual ages.
Next question was, how can I get my neurologist to consider the possibility that I might have NPH and not Parkinson's or Alzheimer's?
Yeah, it's a tough one. I would have thought that most competent neurologists would consider NPH as part of the differential diagnosis when there are appropriate signs and symptoms. And we talked about the problems with gait abnormality, urinary difficulty, cognitive problems, and often it's a condition that starts with gait problems, walking problems. In fact, the walking problem can look very similar to somebody who has Parkinson's disease. But there are things that will distinguish it from Parkinson's disease. But having said that, there is a small subgroup that bounce back and forth between the movement disorder neurologists and neurologists who deal with NPH and neurosurgeons. But once that triad starts to emerge, I think it starts to become evident that this is a condition that needs to be explored. Having said that, we all know the healthcare profession has a variety of competencies, and everybody will have encountered physicians that they're not entirely happy with and may not be addressing all their needs. I think in that situation, really the best thing to do is to try and take control of your own health. And if it's something you are specifically concerned about, then it's something you should specifically ask your family doctor about, or ask your neurologist about. If they are sitting there and talking about Parkinson's disease and you don't express to them that you have this concern about NPH, it's going to be hard for them to address that question. If you do ask them, they may in fact have very good reasons for thinking that you in fact have Parkinson's disease or Parkinsonian syndrome rather than NPH. And similarly with Alzheimer's. It is something that we get sent periodically, somebody who has a primary dementing illness, so Alzheimer's would be the most common of that. And of course, at the end stage of Alzheimer's, they often have terrible problems walking as the brain just simply becomes more and more destroyed by this overwhelmingly terrible disease. And if you do scans of these individuals, by definition, the ventricles will get bigger. If you think about as an infant, our head's tiny. As our brain grows, the head grows with it, and then the sutures fuse, and now our head is fixed to that size. As we get older, and by older I mean anything over 25, we start to lose neurons. As we lose neurons, our brain starts to get smaller, and that becomes something we can see on scans in individuals who are in their 50s, 60s, and 70s. So the brain just gets smaller and smaller and smaller, and the skull doesn't, which means that the cavities get bigger and bigger and bigger as we age. And then when you're hit with a disease, so in that scenario, we look at an MRI or a CT scan of somebody in adulthood, and we say, there's some atrophy that's appropriate for age. You know, this is a 70-year-old, the brain looks like a 70-year-old brain. But in a setting where you have primarily dementing illnesses, the brain starts to lose substance and the ventricles get very big. So these are people who have big ventricles and are demented. And the question of NPH does come up. In a primary dementing process, it's an unlikely diagnosis. But again, I would just simply advise, if it is something that crosses your mind, it's something you should vocalize to your family doctor or for your neurologist to have them consider it.
I don't know if this one ties in a little bit here, but it's, the question was, I was referred to a neurologist to get a diagnosis. He was not familiar with NPH, but I have all of the symptoms: gait, bladder incontinence, and memory loss. How can I find a neurologist who is aware of NPH as a possible diagnosis?
They're good practical questions. And I would have said, if this is indeed the case, I mean, a neurologist, it's unusual for a neurologist not to be aware of this condition. I would have thought that to be unusual. And if they're sort of ignoring the possibility of this, again, it behooves you to mention that if that's something you're concerned about. But if this is indeed the case and you have a neurologist who simply is not considering this and has no interest in thinking of this, I see nothing wrong with asking your family doctor to refer you for a second opinion. Now, having said that, on the physician's end, the internet is a wonderful thing, but it is also somewhat dangerous because we do have many individuals who come into the clinics who already know what they have or think they know what they have because they've gone on the websites and they've looked at the list of symptoms, and often the list of symptoms is that big, and they'll say, well, I have that and that and that, so I must have this condition. And the reality is the pattern may not fit, and sometimes it's just an issue of spending a little time and talking to an individual and to say, well, indeed you have these symptoms, but this aspect of your gait or this aspect of your cognition don't fit with this pattern and fit more likely with that pattern. But in this day and age, it's a discussion that needs to be had with your specialist. You need to have a specialist that you can feel comfortable that you can talk to them about this, and if you have concerns, ask them questions about this.
This clearly wasn't from me. Again, I'm just reading the questions. I'm a woman in my 20s, recently diagnosed with hydrocephalus. I had an ETV 4 months ago. My husband and I would like to now have a baby. What should I do to prepare for before getting pregnant, during my pregnancy, and after? How often should I see my neurosurgeon? And will he discuss my care with my OB/GYN and vice versa?
Take folate. And beyond that, an ETV should not change the care of your pregnancy or your delivery one bit. Once you've done an ETV and you have a functioning ETV, then you have the brain that's the CSF is now in a new state of balance, and there are no issues related to pregnancy and delivery that should change this. I've never really had specific conversations with obstetricians about patients who go through this, and if the obstetrician has some discomfort about this, they'll often call us directly. So this is a conversation that goes on, but there's really no need to have routine follow-ups with your neurosurgeon during this period of time.
Okay, and the last question that we had from those that wrote in, again, we'll open up to the floor in a few moments' time for some questions. If anybody has any, I can bring the microphone around, so we'll get to that in a moment. But the last question was, I was diagnosed with hydrocephalus at birth and am now in my 50s. What is known about aging with the condition? Is there any research currently underway about aging and hydrocephalus?
It's a good question because it's general. I like this. We're diagnosed with hydrocephalus at birth, but it doesn't say whether you were shunted or not. And I think they're two different issues. There are some individuals, and I talked a little bit about it before, who may have had a big head at birth, may have been told they had hydrocephalus, and yet developmentally they were fine. They didn't have symptoms. It kind of ties in with Dr. Kulkarni's question about, do you do something with somebody with big ventricles? They go into adulthood and they have big ventricles. And we've thought of this as being compensated or arrested hydrocephalus. It's not clear to me that these individuals need routine follow-up. But there is a potential that as they age, these individuals may be at a higher risk of developing the symptoms of normal pressure hydrocephalus that we're seeing in the so-called idiopathic NPH group. So the idiopathic group is a group of individuals that have nothing wrong with their brain that we can tell and no predisposing conditions and develop these symptoms. And then this group that we refer to as secondary NPH would be individuals who have potentially what looks like congenital hydrocephalus and are completely asymptomatic until their late adult years. So it is possible that the presence of hydrocephalus that's not been treated may put one in that subgroup that might be at risk of developing NPH. And if symptoms appear, then that's something that needs to be addressed and you need to get attention for that. Treated hydrocephalus, so adequately treated hydrocephalus in a person who's functioning neurologically normally, there's no research that I'm aware of that is specifically looking at the issue of aging in this group. So I kind of look at this as primarily a mechanical issue. They've got a piece of plumbing in place that is working and their brain's functioning fine, and it's the issue of how long will that plumbing last. It doesn't need to be routinely checked. And individuals have often talked to me about, should I have a routine follow-up? And I tend not to see people routinely who have had shunts for many, many years. I make sure that they're aware I'm available and that I can be their first go-to if there's an issue. But the reality is I could see you today and you're perfectly fine and your shunt could block tomorrow. And seeing you is not a means of making it any safer for you to carry on a day-to-day basis. As I said, it's mainly an issue of mechanical problems with the shunt that can occur at any point in time over life, but are no more likely to occur in adulthood than they are in the pediatric age group. Yeah, I think that covers most of that.
So we will open up to the floor for any questions. If you have a question, maybe you can just raise your hand. I'll come around with the microphone. I'll try to get to everybody. If you have a question, then you can address it specifically to Dr. Kulkarni or to Dr. Parrent. And maybe if you just state your name as well for those that are watching or listening on the webcast as well.
Hi, my name is Jenna, and this is kind of a question for both doctors. I've had many shunt surgeries in the past, and I know that recovery is pretty quick after shunt surgery. I've gone home the next day. But what is it like for after having ETV?
It can be similar too, yeah. I mean, but barring any complications, the recovery isn't that much different. Depending on the scenario, sometimes if it's somebody I'm a bit more worried about because I'm not sure the ETV is going to work, then we might watch them a bit longer in hospital. But otherwise, the recovery itself shouldn't be much different.
And also, does it take about the same amount of time for surgery for ETV opposed to shunt?
Yeah, sometimes it can even be quicker to do an ETV if it goes very smoothly, yeah.
Hi, my name is Angela. You spoke about ETV and risk of pregnancy, which doesn't sound like there is, other than normal pregnancy. What about shunting, VP shunting and pregnancy?
We've not seen an increased incidence of problems with individuals who've had shunts. The question is always raised because a VP shunt, so the shunt is in the peritoneal cavity. You're draining fluid from the head into the peritoneal cavity. The only way that works is if the pressure in the head is higher than the pressure in the peritoneal cavity. And of course, when you've got a big mass in there, because of the fetus, and then the pressures in the abdomen may be higher. So at least theoretically, one might wonder whether the pressures built up the shunt may not function as effectively. But the reality is, we've not seen that. So practically speaking, it's not an issue. The bigger issue we face is when I've had the odd call from somebody who's doing a cesarean, and they say, I've got this white piece of tubing that's come through the opening here as I'm doing a cesarean. What should I do with it? And the answer is just tuck it back inside and ignore it. And for the most part, it's a non-issue.
For someone who's come to you as a transitional patient, they were shunted as a child, and maybe now they are a good candidate for ETV as an adult. Is there data to talk about how successful an ETV is at that point?
There are some data, yes. A lot of it has to do with the cause of hydrocephalus. And it's interesting, this is, you're going to get different responses from different neurosurgeons, so I'll start off by saying that. I have a personal philosophy, and I'll tell you what that is. And I try to teach that to our residents, because often what commonly happens is somebody comes to the door and they might have what looks like a blocked shunt, and the call I'll get from one of our residents is that I have somebody with a blocked shunt. We've done the test, it's blocked, I'm going to put them on the board, we should probably replace their shunt. And my question is always, what caused their hydrocephalus? Well, why do you care? Well, because if it's caused by a condition that we can now treat with an endoscopic third ventriculoscopy, my procedure of choice would be an ETV, and I would then have that discussion. If somebody's coming for me for their first transition visit, we will often get into a discussion of this. And if I don't have the relevant background imaging, I'll try to acquire that, and we'll have a second follow-up visit. But the idea would be to look at the underlying cause of the hydrocephalus. So many individuals who are in their 20s or 30s now will have had a shunt when ETV really wasn't something that was considered early in the course, or the individual was less than a year old and they happen to have had a shunt put in that's been very effective. Now, you would never have thought of doing an ETV under 6 months or under a year because the success rate is so low. But that person who's now an adult, the success rate now becomes higher. So I would then review the underlying cause of the hydrocephalus, and then we would have a frank discussion about what the success rate would be in an ETV and what the risks would be in an ETV. Now, another scenario we have is individuals who run into intermittent symptoms. So it appears as if their shunt is intermittently malfunctioning, and they're coming to me and they're now feeling well, and they're saying, like, what should I be doing? I want this resolved. And we have had rare individuals where we've planned a course of action to carry out an ETV where the pathology is appropriate. So Dr. Kulkarni had mentioned one of the things we look at is ventricular size. If somebody is well shunted, their ventricles may be quite small, and it's very difficult to get an endoscope in there. So we have on some occasions admitted somebody to the hospital, taken the lower end of their shunt out, and it connected it externally and allowed the pressure in the head to enlarge under controlled conditions, allowed the ventricles to get enlarged, and then we would do an elective endoscopic third ventriculoscopy. But this is a discussion we would have on an individual basis to sort out what's best for them.
I have 2 questions. I have been recently, I had a shunt put in 2007, and about 11 months later I had a colonoscopy. I have recently been told that I have a growth on my pancreas, which has increased from 2 centimeters to 4. But they tell me that they can't do anything because of my shunt. Would you know why it would be different than my colonoscopy?
I can try to address that. It's going to be hard to give you very specific information without knowing the specifics of what they're seeing on the scans. But the differences between a colonoscopy and opening the abdomen is that when you're inside the colon, you're not actually inside the peritoneal cavity. The cavity that contains your bowels the inside of the bowel doesn't communicate with that cavity. So when you're inside the colon and working away with a scope, you're not anywhere near where a shunt would be. You're in a completely different space. Once you open up the abdomen, then you're now inside of a space where the shunt catheter would be. Having said that, many individuals have had surgery on their abdomen when they have a shunt in place. And if we know they have a shunt in place, the general surgeon will often call us and say, we're looking at doing this operation, what sorts of things should we be thinking about? The obvious things for us is we think about the possibility of an infection, the possibility that there may be blood, etc., in the abdomen that may interfere with the functioning of the shunt. But these are things that we at least become aware of and can be attuned to and can look for problems after surgery in the abdomen. So without knowing the specifics of what the specific issues are in your abdomen, it's hard to give you specific advice. But in general terms, people can operate on the abdomen in somebody who has a shunt. And it is distinctly different than doing endoscopic procedures when you're really very protected from the shunt.
Okay, my other question is, my shunt was put in 2007, and I've never had a problem anyway. And I've only improved in my cognition and my walking and so on. Should I be expecting something to happen?
Sounds like you've done very, very well with your shunt. That's very nice to hear. Well, the reality is we are all aging, and as we age, there are a bunch of concurrent things that can occur, but we don't know how long the improvements that occur when you shunt somebody with normal pressure hydrocephalus will continue. They can certainly go on for many, many, many years. I have individuals I've been following for 10 or more years who will continue to show improvements, but if I look at them now and look at their videotapes now and look at their cognitive testing now, it may be marginally different than it was 10 years ago, but I would argue if you look at a 90-year-old and assess them and compare them to an 80-year-old, there will be changes that we would attribute to normal aging. So the normal aging process will come into play, but as long as your shunt's functioning, it should be addressing the issues specific to the normal pressure hydrocephalus.
Thank you.
Could you explain the term normal pressure hydrocephalus and why that term was applied when it would seem if the ventricles are enlarged that the pressure is not normal?
It's a very astute question, and there's a lot of researchers that are trying to figure that out. So it is the presence of ventriculomegaly, which is just a fancy medical term that means big ventricles. So big ventricles in the setting of these symptoms. And if you put a needle in the lumbar spine and do a spinal tap and measure the pressure is completely normal. So it is indeed hydrocephalus, but the pressure is normal. The question I think you're getting at is, well, how does this occur? And it's not entirely clear, but there appears to be, as opposed to problems where there's a blockage, an acute blockage to CSF, people get into raised pressure. So to put it in perspective, we contain about 150 cc's of spinal fluid between the brain and the spine. We make about 20 cc's an hour, so almost 500 cc's a day, half a liter. We turn our CSF over 3 times daily. So we have a very efficient system inside there that produces spinal fluid and absorbs it. It washes out our CNS. If there's some imbalance in that, if there's a mismatch between the rate at which we absorb fluid and the rate at which we make fluid, then the ventricles may slowly dilate without there being necessarily a huge increase in pressure. That's one thought. Another thought is that at some point in time, the pressure increased, the ventricles expanded to accommodate that, and now with the expanded ventricles, the pressure has dropped down to normal. If we actually put a pressure monitor inside the head and measure the pressure over a 24-hour period of time, it isn't absolutely normal. It actually measures as being in a normal range. Normal pressure is anywhere between or up to about 20 centimeters of water pressure. So if you attach a manometer and watch the fluid come up, it'll start to fluctuate at about less than 20 centimeters. That's normal. If you put in a monitor and monitor it over a long period of time, you may see some abnormal waves that periodically appear. That suggests, although the pressure is normal, the compliance, or it's a relatively tight brain. It's a very complex answer to a simple question, but the reality is the pressure is normal, and that's why we call it NPH. To distinguish it from the subgroup of individuals where they have an acute obstruction, the fluid backs up and the pressure raises, and they present with severe headaches, decreasing level of consciousness, changes in their vision, etc., whereas this group presents with this syndrome of decline in gait, decline in urinary control, decline in cognitive function.
I have a question following what you were just talking about with headaches. Now, I have arrested hydrocephalus. I had one shunt put in when I was an infant, and another one was put in after because one blocked. And I haven't had any problems so far. But I'm wondering about headaches. Are they more common amongst those of us with hydrocephalus? And you probably already answered it, but in terms of a migraine, what would be the difference between an ordinary migraine and something that you really should be worried about? Is it frequency? Is it level of pain? Is it, do you have anything to comment on?
The problem is having a shunt in place and having hydrocephalus doesn't protect you from having migraine headaches. So, migraines and things like that are common. So you're quite right. If you happen to have a shunt and you happen to have migraine headaches, then one is somewhat cursed because it's hard to sort that out on some occasions. In general, if somebody has a blocked shunt, then we don't usually think of that as something that will simply go away. Whereas a migraine headache has a finite lifespan in the majority of individuals. And most people who have had it for a period of time understand the pattern of their migraines. So when they have headaches that are unusual or out of character, that's what alerts them. But as a general rule, when we think of a problem arising with a shunt, it's usually something that starts and if it presents itself and progresses, as opposed to terrible headache goes away, a week later terrible headache goes away. You start to think, although we can think of intermittent shunts, intermittent obstructions in some individuals, often it's not the scenario that's associated with a shunt obstruction. But it's not entirely clear-cut, and it's hard sometimes to sort that out, even in experienced hands. We often rely on individuals. I know when I was doing my pediatric stints, when mom came in and said, this is a blocked shunt, you usually knew it was a blocked shunt because they recognized that pattern of symptoms in their child, even though their child may have a different pattern of symptoms than some other child. But it's a person's own familiarity. Sounds to me like you've been blessed with the fact that your shunt is not obstructed very frequently, so you're not faced with this scenario too often, which is very nice for you.
Absolutely, thank you.
Any other questions? Yep. Okay. Really filled on in here.
I'm just wondering what the protocol is for adults with hydrocephalus or spina bifida and hydrocephalus when they go to an emergency room and they're showing symptoms of shunt failure, but the residents or whoever is seeing them just thinks it's a headache and sends them home.
I'm being called to answer for all the evils of our medical system. The reality is there's not a protocol per se, and it depends on whether you show up in a hospital in St. Catharines, Ontario, or Welland, Ontario, or Toronto Western Hospital. I think you are going to be treated differently. The presence of a shunt will always make the referring or the emerge doctor tend to be sensitized to this fact that this might be related to something wrong with the shunt. Again, I remember in my pediatric experience having, it was a pair of twin boys who both showed up in the emergency department with nausea, vomiting, and fever. One had a shunt, one didn't. So they said, you've got the flu and you must be a blocked shunt. We better send you to the neurosurgeon. And the reality is they both had the flu. So if anything, people tend to overcall it rather than undercall it. But there's no question people have been sent home from hospitals where they come in with a headache and we think, well, it's just a headache, we'll treat it, it'll go away, and it's progressed. But there isn't a protocol per se, but I would imagine that if people are aware that you have a shunt, they tend to err on the side of attributing symptoms to a shunt. So the difficult to manage patient, one of the difficult to manage patients in the adult world is somebody who has chronic headaches and has a shunt. Because they show up to the emerge sometimes because they have just an absolutely unmanageable headache, and they know it's their migraine, or they know it's something that they have, but no, they want to shave the back of their head and do a shunt study every time they show up to try and get a shot of some medication to help them. But I don't think the risk of being unrecognized is exceedingly high.
Hi there, it's Mark, and I have two quick questions. The first one is, if you have a shunt reservoir and you're looking to either check for the clarity of the fluid, if there's an infection concern, or you're looking for an opening ICP measurement, is there a reason why you wouldn't want to use that reservoir and tap the shunt as opposed to go to LP? That would be my first question. And then the second quick one is, long-term shunted patients, if they become concussed, is the brain going to respond differently in its recovery?
For shunt tapping, there is a slight risk of infection, but if you're already tapping it, I don't see a reason not to access CSF from that as well. This is the only scenario where that might be difficult in somebody who has very small ventricles, and then you may not get much CSF from that shunt tap. So that's to answer that question. And the issue about said concussion with shunts, I don't have good data on that, and I don't know if Andy's aware of anything, but I would have to believe that because the brain dynamics are altered, I do suggest that there may be a slight increased risk of concussion in the presence of a shunt, but I don't have evidence to back that up.
No, me neither. The only other issue that can arise is that, and I've heard this discussed, and I don't know what the reality is that whether you can have meningitis and the ventricular fluid, which is where it's produced, right? The ventricular fluid gets flushed through, but whether the lumbar fluid may show signs of infection where the the fluid pulled from the ventricles may not. I'm not aware of instances where that's been the case, but I've heard it discussed where somebody is febrile and we've tapped the shunt looks clear. I wonder if we shouldn't just do an LP to make sure that it's, we're not missing something.
Hi there. One question about risk factors in adult onset of NPH. Are there any known risk factors that
There are. So idiopathic NPH is, by very definition, there's no known risk factors. The secondary NPHs are conditions where somebody's had a prior head injury, prior bout of infection or meningitis, or a prior hemorrhage. And head injury basically amounts to hemorrhage, the same thing. So the fluid, as we said, is produced in the ventricles, goes through the ventricles, comes out of the ventricles, goes down the spine, surrounds the brain, and it's absorbed along an area called the sagittal sinus through these things called the arachnoid granulations. And there's a belief that the presence of blood or pus can cause these to scar over, and therefore your efficiency of absorbing fluid may be lower. And so there's a group of patients who have what we call secondary NPH who have that as a predisposing risk factor.
Okay, we'll take two more questions, I think, and then we'll take a brief break shortly for lunch and then do our work presentation. We have two left here.
My name is Ipek, and I was just wondering, I know you said that shunts don't last forever, but are there things that I can do that can delay a shunt malfunction?
No, not that I'm aware of, really.
So there are no factors that cause
No. I mean, you're fully grown now, so I mean, growth is one issue that is practically related to the length of the shunt tubing. But in an adult, you're just simply dealing with materials that are sitting inside the body, and over time, they just may stop functioning or not function well. But there isn't anything specific that you can do that will make that any better or any worse.
Hi, it's Jen again. I know from past experience, the two main tests that are done to check if there is a shunt problem is ultrasound or X-ray and CT. Why are they mainly the top ones and not like ultrasound?
Well, the information you're trying to gain from that, the CT scan is to look at whether there's a change in the ventricle size. So an alternative to that would be an MRI. To look at ventricle size with ultrasound, you need some sort of a hole in the skull, basically, and so typically we can only do that in infants. So an infant who has a soft spot still, then we'll use ultrasound to look at the ventricle size, but for anybody else, we need to do either CT or MRI. The X-rays for the shunt give us different information. That doesn't tell us the size of the ventricles. That just tells us whether there's anything physically wrong with the shunt. Is it broken somewhere, for example, or something disconnected? So they're giving us complementary information, and there's not really a replacement for the X-ray. The ultrasound wouldn't give us that same type of information.
I want to obviously thank Dr. Parrent and Dr. Kulkarni for coming in today and sharing their expertise and taking the last half hour or so as well to answer all your questions here live. So if we can, just show our appreciation for the two doctors, and again, thank them for coming in.